Hello, everyone. I would like to welcome everyone to the CME series on lysosomal disorders. This is the fourth season for this very afterthought event, and I am the host of this series, Ozlem Goker-Alpan. Today, we're going to be talking about the brain and lysosomal disorders. And this is not the first time we're discussing this topic and why we're coming over and over, simply because has many referred to the brain as the most vulnerable and least forgiving organ is invariably involved in almost all the lysosomal disorders. So why we can ask the question, why does lysosomal dysfunction is a primary impact on the nervous system, and why we are ubiquitously seeing nervous system involvement in when there is lysosomal dysfunction. The reason is the neurons are highly dependent on the lysosomal system because they are long-lived and they're the post-mitotic cells, and they have highly extended axonal processes. Let's ask the question in a reverse way. Why lysosomes are essential for neuronal health? So, because the postmitotic neurons require lysosomes for normal cell function, which basically requires getting rid of the intracellular waste to prevent the accumulation of damaged misfolded proteins. This is also how the cell death is regulated through autophagy and other cell death pathways the lysosomes are directly involved with. In addition, there is the mitochondrial involvement, and we know that the energy depletion is a major impact on the lysosomes too. And when we collectively look at the more than 50% recognized type of the lysosomal disorders, basically that sphingolipidosis are the main patient population we see, but in all the other conditions, actually that is a nervous system is involved one way or another, including even the disorders such as Pompe disease in the late onset, even though it's a a major muscle disease, but we know that with the increasing evidence, the CNS is also involved with strokes and so on and so forth. So this pie chart represents the percentage of the lysosomal disorders that comes to the clinic with brain involvement. The proportions are just for illustrative, so it's not really exact depicting the percentage, but the majority of the conditions that come with a CNS presentation is the neuronoceroid lipofuscinosis, leukodystrophies, and also the MPS, the neuronal types. And also we have the Fabry disease, where there is the strokes, and the white matter involvement is also can be another form of CNS involvement. So when we look at the disease spectrum in the lysosomal disorders with the neuronal involvement or CNS involvement, so the MPS is with the attenuated forms, or we call them non-neuronopathic, but some of them may have some mild manifestations of neuronal involvement. And then we have the Tay-Sachs, the late onset forms, and then the Gaucher disease, Fabry, and Pompe diseases on the other side. So in most disorders, there is a juvenile and infantile form, and then in some, the neurodegenerative, the process begins in utero, such as MPS types 4, 7, and Gaucher type 2. So these are our learning objectives today, and I would like to invite our speaker, Dr. Raphael Schiffmann, Rafi Schiffmann, who is a colleague, friend, and mentor for over 20 years. Dr. Schiffmann is an international expert in lysosomal storage and other rare neurodegenerative diseases. Trained as a neurologist, he often refers himself as the research neurologist because he has decades of experience advancing both clinical and translational and also drug development research. So he has done pioneering studies on the neurological manifestations of multiple lysosomal disorders, and that shaped the field's understanding of disease mechanisms, treatment approaches, biomarkers, and the list is very wide and long. And so without much, actually, that's spending time on Rafi's experiences, I would like to give the word to him, and then for this wonderful presentation that we're going to have for the next hour.
Thank you so much, Ozlem, for this generous introduction, and your introduction to my talk is really excellent. Um, Hello, everybody. These are my disclosures. I'm basically a consultant for a number of biotechnology companies in the field. Um, so the whole concept of lysosomal uh, diseases is that they are caused by errors in a gene that produces enzyme that take out and recycle the rubbish. If the recycling enzyme is missing or deficient, the rubbish or garbage accumulates and builds up in lysosome of cells to toxic levels. You can see here on the left-hand side a normal neuron, and to its right a neuron chock full of lysosomal storage. So the idea was that it's like in your kitchen when you don't throw away the garbage, it accumulates, and obviously you cannot cook and work there when there's so much stuff there. The, re- the reality, of course, is much more interesting and complex. Here is the pathogenic cascade. Of course, on top is the gene defect, the protein uh, defect as a result, and then there is substrate accumulation, which causes a complex downstream pathogenic cascade that we're trying to understand, and it's not easy to figure out, which leads to cell dysfunction and death on many occasions, and of course, rheumatic disease. So, a few words about the mechanisms of disease in lysosomal conditions. We can divide them into non-specific mechanism and specific ones. Let's show example of a non-specific mechanism. You can see on the left-hand side um, that a description of autophagy. A defect in autophagy is the most commonly cited non-specific mechanism in the majority of lysosomal diseases. He's depicted Pompe disease, Gaucher disease, Niemann-Pick type C, mucopolysaccharidosis, and free salicylic acid storage disease as an example. This is a process where the cell recycles its components, and it consists of a vesicle that takes up the cargo, matures, and eventually fuses with a lysosome. And the catabolic enzyme in the lysosome break down the material, which can be membrane or organelles, and digest it to its small molecules, which then are recycled. This causes mitochondrial dysfunction, neuroinflammation, oxidative stress, and in many cases can lead to cell death by apoptosis, for example. On the right-hand side, it's the same idea, but here the author emphasizes the secondary accumulation of glycosphingolipid because the primary substrate, when it accumulates, can inhibit other catabolic enzymes, and that leads to secondary storage and defective phagosome lysosome fusion, which, as I discussed, leads to tertiary storage and cell damage and dysfunction and death. So let's talk about an example of a specific mechanism. There are very few specific mechanisms that have been described and identified in lysosomal diseases. One of them, which I particularly like, is GM1 gangliosidosis, which is in general beta-galactosidase deficiency. It is a combination of a disease of the brain and of this skeleton, and can present at different ages. And the earlier, the more severe it is. It's basically a combination of skeletal dysplasia and brain disease. Uh, so the investigator checked the brain of models and of humans under the electron microscope, and they found an increase formation of contact sites between the endoplasmic reticulum, or ER, and the mitochondria here in the middle, and the ER on both sides, and these are the contact sites. So they investigated that, and their conclusion was that the GM1 ganglioside does not only accumulate in lysosome, but also in the endoplasmic reticulum, the ER. The accumulation of this glycosphingolipid promotes the formation of uh, pores between that link the ER and the mitochondria, and lets excessive amount of ionized calcium in to the mitochondria, which leads to apoptosis. So this is a very nice specific mechanism that has been discovered. Let's switch now to the neurological manifestations of these diseases, and basically anything that can go wrong with the brain can occur in lysosomal disease. This includes developmental delay and cognitive regression, seizures, myoclonus, hypotonia evolving to spasticity, and mixed tone abnormalities, cerebellar ataxia, and gait disturbance. Extrapyramidal signs, psychiatric behavioral abnormalities are common, and loss of vision. Now, it's not only the CNS that is involved, the peripheral nervous system can be involved, for example, in Fabry disease, this small fiber neuropathy, and in the leukodystrophies, there is a demyelinating neuropathy of larger fibers. In addition, as you heard already from Dr. Goker-Alpan, for example, cataplexy is quite specific for Niemann-Pick C. Fabry disease has a propensity for ischemic stroke, and there's a lot of neuro-ophthalmological signs and abnormalities, both of the retina and the movements of the eye, which I will emphasize. Sensorineural hearing loss, sleep disturbance, autonomic dysfunction is seen in particular in Fabry disease and the chronic form of GM2 gangliosidosis. Now, last but not least, is bulbar dysfunction, which is really critical because it leads to dysphagia and aspiration, which of course leads to a progressive or acute respiratory insufficiency, and is the major cause of shortening the life of these patients. These diseases, of course, present in childhood, infancy, and childhood, and as Dr. Goker-Alpan emphasized, they include in particular Krabbe disease and monochromatic leukodystrophy, both leukodystrophies, Niemann-Pick type C or NPC, GM1 and GM2 gangliosidosis, the neuronal cerebelloplasminosis, and of course the neuronopathic mucopolysaccharidosis. However, these diseases can present in adults, and this is very important to realize because it's very often unidentified and and lead to a delay in diagnosis. So what I like to emphasize here is the psychiatric and behavioral changes that can occur primarily before other abnormalities. There is even a form of metachromatic leukodystrophy that does not have any motor dysfunction, only behavioral and cognitive changes. Similarly, in hemopig C, we know we identify only a third of the patients that we expect, and I think the majority are hiding in psychiatric wards because of the presentation of uh, cognitive and psychiatric abnormalities. Adult onset GM2 gangliosidosis is important to be aware that it can present as lower motor neuron disease that very much looks like spinal muscular atrophy or ALS. So when you have a picture like this, always check for GM2 gangliosidosis. And of course, they develop later cerebral ataxia and other abnormalities. And of course, you see cerebellar atrophy on the MRI. Fabry disease, neuropathic pain due to small fiber neuropathy, deficiency in perception of cold, and more propensity for stroke and vestibular cochlear involvement. And finally, Gaucher disease type 3 can present in adulthood, either extension from childhood into adulthood or new onset in adulthood with supranuclear slow horizontal saccades, ataxia, seizures, cognitive abnormalities, etc. So how to evaluate and follow neurological involvement in a patient with lysosomal disease? So it's very important to perform a detailed history, including family history, of course, in a genetic disorder, and a good general examination and comprehensive neurological examination. So in a neurological examination, you cannot skip really anything. You have to look at the mental status and development depending on the age, motor and cognitive skills, social, emotional abilities, and of course, observe their speech and thought processes. The cranial nerves are critical in particular examination of the movement of the eyes. You have to know the difference between saccade and pursuit eye movements. Check the hearing since hearing impairment is common. Motor function should be examined in detail. Tendon reflexes checked from the jaw to the ankle. And plantar responses are important also because when they are upgoing, but when you have a Babinski sign, it is an indication of the involvement of the uh, pyramidal nervous system. Um, Sensory function is important, but it's very hard to assess reliably in children and individuals with poor cognition. Coordination um, um, and balance should be checked. And of course, the gait spasticity and weakness can be present. I strongly recommend, and this is what I do every time I see someone with such a disease. I record by video their examination, especially the gait. And this way I can assess it over the years in a precise way. So examples of neurological and other findings. So of course you have to look at the neurology in Fabry disease, but also don't forget the skin, the angiokeratomas in the skin that is seen uh, practically exclusively in classic males. In hemopig C, exactly, again, the vertical eye movement abnormalities should be looked for, dystonia, ataxia, and cognitive impairment. Uh, Gaucher disease, instead of b- vertical, it's horizontal supranuclear gas palsy, and the other abnormalities I described. Um, Reflexes changes are common in metachromatic leukodystrophy, and importantly, in mucopolysaccharidosis, you should be aware that in addition, there's a propensity to develop hydrocephalus, in particular in MPS1 children, and spinal cord compression and other skeletal abnormalities that can be significant. So what tools can we use to follow up um, individuals with lysosomal diseases? So neuroimaging is a very useful one that is unfortunately underutilized. Here in the example on the left-hand side, gene 1 and gene 2 gangliosidosis, measurement of the volume of the basal ganglia and white matter. The volume in general, the volume is the most commonly assessed uh, parameter in neuroimaging and can be measured extremely precisely. Uh, you can see that the infantile form progresses faster than the juvenile form, and you can compare with the normal controls that they have. uh, Very, very nice here. And similarly, in the white matter, you, you can see the differences in the volume of the white matter in the patients compared to control. Another nice study on the right-hand side, CLN3, where they studied repeatedly and showed a decline, quantitative decline in the cortex volume, white matter, cerebellum, and other areas in the brain. And of course, when you have that, when you have a decline in the volume of the brain, you always have an increase in the size of the lateral ventricles due to atrophy. You can also score the MRI here cross-sectionally. They scored in the infantile form, and differences, of course, in the progression between the infantile and the juvenile. Or you can follow individual subjects longitudinally, and you can see the difference. The bottom line is that there's often a correlation between the changes in the volume and the behavioral and neurological abnormalities, which validate the usefulness and the importance of these assessments. And here you can see in a number of areas in the brain the significant correlation between the volume and the Vineland. We studied a number of years ago individuals with Gaucher type 3, that they were all adults, on substrate reduction therapy, on Figlostat, on Venglustat. And what we saw, all the, the blue diamonds are individuals who had good drug exposure. So you can see they tended to have actually an increase in the volume of the brain over 1 year. By chance, we had one participant who did not have any drug exposure after the first few weeks, and this individual shows largely atrophy, which again, in combination with enlargements of the ventricles. Um, Uh, the biomarkers, you can measure a number of things in the blood and the CSF. Here is an example of neurofilament light chain, which has been very useful um, in neurology in general and has been used in many diseases. On the left-hand side, Pompe disease, you can see over the years that their neurofilament light chain, or NFL, increases with age, while the control will, basically decreases. And that's really, it shows the critical importance of measuring mm, the patients and with controls of a similar age. On the right-hand side is work by the Goker-Alpan group in Gaucher disease, again, looking at neurofilament light chain. And what they show is that in Gaucher type 1, but there's no primary neurological involvement in the patients, no one has elevated NFL, neurofilament light chain in the blood, but while those with the acute form, the most severe form of Gaucher type 2, everyone has elevated NFL. And as expected in the more chronic form, Gaucher type 3, some have elevation of NFL and some uh, do not. So I really hope that this is going to be used as one of the important indicators of clinical efficacy in a trial and also in clinical practice. So there are, of course, it's very important to have cognitive and psychomotor uh, tools to follow the patients, and we divide them by non-specific ones and specific disease specific ones. So how do we monitor them? First of all, we use standardized developmentally appropriate neurocognitive batteries at baseline and regular intervals, depending on the age of the patient. The non-specific ones include the R bands, the Violent, the Bailey, and disability differential ability scales. Uh, these are quite well known. Importantly, there are a few disease-specific scales that have been used and actually were found to be quite useful in clinical trials. There are very few, basically three plus a few in Fabry disease, which is particularly people use disease patient-reported outcome or PRO. For example, there was one that was recently developed by Sanofi. Unfortunately, it's not freely available. Additional testing recommendations for neuropathic lysosomal diseases in individuals with sensory, motor, behavioral, and systemic comorbidities. I recommend this article, which describes the importance of taking all this, the other abnormalities that the patients have into account. As I mentioned, restricted access to some of these uh, tools because they're proprietary is a problem. So what I use often is, of course, emphasis on the interviews, and I follow the medication use, which can sometimes be quite revealing. So you can depict the trajectory of this works only in children. And here you can express the developmental age that you assess in a variety of ways with the chronological age, and normally in this gray line, of course, they are clearly correlated and should be in theory identical. But what you can see here quite nicely is in this individual, gross motor lags the most uh, behind the correct developmental abilities, while a receptive language uh, follows the normal developmental progression uh, quite closely. So you can use this to assess individuals, but also to assess the natural history, but also a response to a variety of treatments. Again, I like to emphasize hearing loss, visual impairment, sleep difficulties, uh, cardiac abnormalities, and respiratory ones, joint deformities, and swallowing as additional medical complications that should be taken into account when you evaluate such patients. So here is an example of CLN two rating scale, which was used actually to get a drug approved. I like it because of its simplicity also. There's a Weill Cornell version and a Hamburg one. And for example, if you look at gait, it's very easy to assess normal from abnormal but independent gait, abnormal requiring assistance, and non-ambulatory. So the simplicity of this is quite useful. Um, Here is the NIMAPIC C. This severity scale was constructed and developed by the group at the NIH. It has 17 domains. Uh, this number, of course, is quite unyielding in clinical trials. So in practice, what people have been using is the domains of ambulation, swallowing, speech, fine motor, and cognition. So the five domains are being used, but in fact, the FDA actually preferred to use only four for their analysis, and they dropped the fine motor skill. So, and they claim that if you do that, you get uh, less noisy results that are quite that are better than the five domains. Um, So how do you apply these? Here's an example of a drug called arimoclomol in a randomized blinded control trial, a placebo-controlled trial. You can see that those that were on the drug progressed more slowly than those that were on the placebo over 1 year. So that's a quite reliable and clear result. When you don't have a control group such as that, then you use, for example, in registry and open label studies, you use the natural history. If it's high quality and quantitative, you can show here that over a year on this drug, N-acetyl-L-leucine, there was only 20% of the progression expected, expected, if you look at the natural history in untreated individuals. So it's less reliable and convincing, of course, than a randomized control trial, but it can be also quite useful. So how do we monitor? So it's important to integrate multi-domain data on cognition, adaptive behavior, executive behavioral symptoms, but also include sleep and seizure burden and the burden for the caregiver. You have to recognize that the behavioral and executive dysfunction can be prominent even in individuals with global IQ that's near normal, which is seen especially in attenuated forms. You have to corroborate these data with what you see in neurological and ancillary biomarker. Um, and for example, but it has to have relevance to cognition. So of course, the neurological examination, the brain MRI, and the biomarkers in blood and CSF, as I gave you example of. Timing of the assessment is very important. Of course, with pre-treatment at baseline and a frequent post-treatment or on-treatment follow-up using the same instruments to detect treatment-associated changes. It should be a team-based execution in partnership with the caregiver using quiet, sensory, adapted setting, augmentative communication when needed, and scheduling shorter, repeated sessions to optimize the validity in patients with hearing loss, uh, vision impairment, and other such abnormalities. When you are studying groups, it's important to analyze things centrally. Be careful in to make sure that there is radar training, use of translated and validated version of for international cohorts, documentation of the conditions of the testing, and proactive planning for transitions to alternative measures as abilities decline to maintain longitudinal continuity. So that's really important when a subject declines or gets even older, you have to adjust the tool that you use uh, to evaluate that person. So my last slide is a discussion on trends in clinical research to improve the outcome in patients with lysosomal diseases. So the first one is autologous lentivirus, lentiviral hematopoietic stem cell gene therapy. When you take out the individual's stem cells, you culture them in the lab, transduce the healthy gene using a lentiviral vector, and then re-injecting into the recipient, into the patient. Such a treatment has been already approved for hydrochromatic leukodystrophy, of course, as a preventive measure of very early in the course. There's some interesting results of this approach in MPS one, and potentially it is approvable. However, the majority of gene therapy studies use adeno-associated virus or AAV in a number of lysosomal diseases. The problem is that you have to screen for individuals who do not have antibodies against your capsid, and you can lose about half the patients like that in some cases. And after you administer the gene therapy once, everybody develops antibodies against the capsid, so you cannot, with current technology, re-administer or redose. Also, there's a question about the durability of this treatment over the years, and in some situations, there were immunological uh, complications that can be sometimes severe. So there's no question that the future is gene editing, where you correct the mutation, the primary cause of the disease genetically. And this is the future, of course, but the challenge is to make sure that the delivery of vector arrives into almost every cell in the brain. So deliveries has still to be worked on, and of course, efficiency, as well as making sure that there's no off-target effects. But I think that has been that's the future and has been tried in other diseases. You may have heard recently in Huntington disease and others. Friedreich ataxia is another one. Enzyme replacement a therapy engineered for the CNS. So injection of the enzyme into this spinal fluid of the brain, remains proof of concept. This product, starliponase alpha, has been approved, by the way, using the scale that I showed you, and is being used in this form of NCL. Um, there are other ways to improve the injection and the methods of delivering enzyme into the ventricle, into the CSF, and this is being developed and showing some promise. However, small molecules are still going very strong, in particular in these diseases, substrate reduction and pharmacological chaperones. So these are molecules that are specific, and they penetrate and cross the barrier into the brain. Repurposing of old drug has been quite successful recently. N-acetyleucine is a version of a drug that has been used since the 1950s to treat vertigo, has shown improved ataxia in a 3-month study with favorable safety profile, and the long-term disease looks quite promising in terms of stabilization. The other molecule is arimoclomol, was approved in combination with miglustat to stabilize the disease long term, and I show you some of the result. However, there's an increasing use of sophisticated artificial intelligence to solve structures of proteins and enzymes and design rational small molecules that either activate or inhibit the enzyme or the molecule or the protein. And this is really the future. There are, for example, uh, people who develop non-inhibitory pharmacological chaperone to a variety of lysosomal diseases. Uh, the delivery innovation. So here it's also some exciting stuff is the fusion of the therapeutic enzyme with a ligand or part of a ligand. It can be an antibody towards a receptor on the surface of the vascular endothelial cell in the brain. And this way you trick the receptor to let the whole enzyme into the brain. And that shows initial results that are promising, for example, in Hunter disease. For completeness, I mentioned focused ultrasound, breaking of the blood-brain uh, barrier or opening it. It looks interesting in some cases, but I don't think it's going to be widely used. There are optimized other ways to deliver drugs. And what's interesting recently is the engineering of enzymes that that have increased stability and half-life. There's a very interesting example in models of Gaucher disease type 3 recently, um, where they showed using AV that if you use just the wild type enzyme, you get very little therapeutic effect, if any. But if you use all else being equal, the form of the enzyme that is stable with a long half-life, you can practically almost cure the mouse. So this is exciting, especially if it's in combination with a ligand to get the drug into the brain, can be even used as a form of enzyme replacement infusion to correct uh, the nervous system. So all these are active areas of research to increase uh, the delivery of enzyme and the vectors into the brain. That's it. Thank you, and I'll be happy to hear if you have some questions. Thank you very much.
I thank Dr. Schiffmann for this wonderful presentation. So I am opening the presentation for discussion and question. Uh, there is one question from an attendee, and I have few questions if we have time. They're asking whether can you explain why intrathecal ERT seems to be so difficult to develop?
Yeah, I mean, for a number of reasons. First of all, it's invasive, so it's not something that can be done casually in your clinic. Secondary, one problem is that in some cases, such as in the case of glucocerebrosidase in Gaucher disease, the enzyme is very, very unstable in the presence of CSF, and basically uh, it inactivates it really, really quickly. So you have to hope that you have a form of the enzyme that is not inactivated. And finally, even though we deliver it to the CSF, the actual delivery to all parts, to every neurons or uh, brain cell is probably incomplete. So this is some of the reason. But I want to emphasize that even if the treatment is not so impressive initially, in if initiated early in life, really either prior to developing any abnormalities or very early in the process, it can be quite effective.
Okay, I have actually a few other questions, if there is no other question from the audience. So let's just continue with the treatment modalities, the future therapies and innovations. So there are, as you presented, there are small molecule therapies such as substrate reduction and the chaperones, uh, brain penetrant enzyme therapies that are in works and it's going to be coming up, and also the more currently there is, I think, more common AAV mediated gene replacement therapy. So um, given the approval is expected in any of those, which treatment modality you think is gonna deliver the most rapid transformation?
Um, I don't think one can be sure in general. So one has to take one case at a time in order to assess uh, the likelihood. It depends of the efficacy of the particular molecule and its uh, safety. For example, N-acetyl-L-leucine looks very interesting. I mean, in general, if you have a small molecule that goes readily through the blood-brain barrier, it almost ensures a complete delivery to every cell. If you deliver it using AV, there's always going to be areas which are not seeing any, unless there's a tremendous oversecretion and taken up by untransduced cells. So all things being equal, if you have a small molecule, this is highly effective. But by the nature of the treatment, it's easier to access every cell in the brain.
Okay, I guess we're going to be talking about treatment. Dr. Gustavo Mageva, actually, he comments on your excellent presentation. And also, he's asking about your thoughts about the prenatal enzyme replacement therapy for early onset lysosomal disorders and the efficacy of it, potential efficacy of it.
Or prenatal.
Yes, exactly. Yeah.
Yeah, it's something that I did not mention that has been tried in Pompe disease, I think, by the group in UCSF. Um, Yes, but it sounds quite heroic, and I think it was also tried or in Gaucher type 2 cases, or when you expect somebody. Um, we don't have enough experience, I don't think, to reach a firm conclusion. I'm not sure that that will, in the long term, that it's going to be tremendously useful. Again, if you have a small molecule that you can use in the mother that will cross into the placenta, that can be a nice idea. For example, in Gaucher disease, if you have a chaperone that can activate the enzyme inside the uterus, that c- uh, can be great. But in terms of using enzyme to inject prenatally, I don't think we have enough experience.
Yeah, I have one more question about the treatment, and then we can actually have one more question about the patient monitoring. I mean, now there are multiple gene therapy trials for multiple conditions. So, who are the candidate for a gene therapy trial for a neurological disorder? I'll put it this way, like a little bit more explicit. So, are the infantile forms of these conditions are candidates for gene therapy?
Uh, in principle, yes. As a general response to a general question like that, yes. You should not limit it to a particular disease variant, and sure. But one has to do case by case and see in in the condition that you are, the world expert, Gaucher type 2, for example, the onset of the disease is so early that it's prenatal, we think, right? So you really have to. I don't know if gene therapy intervention will help, but in principle, yes. Anyone should be a candidate at any age if there is an efficacious treatment.
Yeah. Okay, so this is the last question we're going to take for treatment because I guess there is no end to it. I want to ask one monitoring question before we close. So, Eden Gill is asking, could we expect any benefit from the gene therapy 2 or 3 years after the trial, like in early GMs, GM1 and GM2?
Yeah, so the durability is a big question here. And there is this study that was, just a few weeks ago published. Uh, Florian Eichler, I think, is the first author, when they injected in two different places, two different ways to treat, I think it was GM2 gangliosidosis. But even there was a clear decline over the years in the efficacy. I think only genetic editing will be a permanent solution. All the AVs, I think, sooner or later will decline in effectiveness. The question is, how many years? And the problem again, what do you do afterwards? How do you eliminate the problem of the antibodies after the first administration?
Yeah. One last actually comment from Dr. Mageva, so who reminds us about the IV use of Ambroxol in expectant mothers. Actually, it is approved in Europe and other countries for premature. Actually, that's for the lung prematurity. I just want to comment. Obviously, the dose might be much different because we know the chaperone dose for Ambroxol is quite different than the expectorant dose. So I have one question about the patient monitoring or actually incorporating to this into the clinical trials too. So for quantitative monitoring, which modality you think is more fruitful, including neuroimaging, biomarkers like neurofilament light chain or other disease-specific biomarkers, or the standardized cognitive behavioral scale or the cognition. So which one would you use
Yeah.
in
So
clinical practice and trials?
So that depends on the disease itself. So, for example, in Niemann-Pick C, as you saw, it's a classic neurodegenerative disorder that there is a clear decline can be seen in a year or two. So there, it's a lot easier to assess, using a clinical who they assess whether you slow the progression of the disease. That's the best way to do a study. However, the other end of the story is what you are tremendously familiar with, Gaucher type 3, where actually there it's so slowly progressive that we cannot use the progression as a way to assess. We have to look for improvement, absolute improvement. And that is facilitated by the fact that a lot of the brain actually remains intact in these patients. So every disease, it's very important not to generalize and to go from one disease to the other, depending on its natural history and the modality that you have. So um, now, that being said, neuroimaging is very sensitive and less noisy than pretty much any clinical uh, tool that you would use. And so it wasn't necessary in CLN2 or in Niemann-Pick C, for example, to show a clinical effect. But in cases that are very slowly progressive, for example, neuroimaging is more sensitive than any clinical aspect, as I think we showed in our initial Venglostad study. So this applies to other disorders also. So depending on the case, you use one method or another. The neurofilament light chain, it's too early to say how sensitive it is um, in assessing a treatment effect.
Okay, unfortunately, our time has run out. And I would like to thank Dr. Schiffmann again for this extremely helpful and wonderful presentation. And we also thank to the sponsors of this program that include Ultragenyx and Takeda. And while I close this session, I would like to invite everyone to our next one in December, and then the speaker will be announced. Thank you very much. Have a great day.